Nice to meet you all. My name is Ria Prasad. I'm a consultant in special care dentistry, and I'm one of the dentists that work at the RHN. So today I'll be looking at the link between oral health and respiratory health in adults with profound complex neurodisability. I'm not a great expert in this topic, but what I do want to discuss is what we have seen in our patients here within the hospital and the studies that we've done. So this is the RHN. It's based in London. It provides rehabilitation and long-term care for adults with a range of neurodisabling conditions. Many of our patients have a very low level of consciousness and are wheelchair dependent. We have a dental team on site, which consists of 3 consultants plus our dental nurse manager. We provide dental treatment for all the residents within the hospital, be it under local anaesthetic or with sedation. And our dental nurse manager, Louise, who you'll be hearing from later, she is leads on the oral care training for staff within the hospital. The residents also get access to the medical team, physiotherapy, speech and language, occupational therapy as well. To start off with, I wasn't quite sure how familiar all of you would be with certain oral care health terms, which I'll be using quite a lot of in the next hour, so I thought I would just run through them. The first one is plaque. So plaque is a soft, sticky deposit that contains many types of bacteria. It can be removed by toothbrushing or flossing. We then have calculus. This is essentially calcified plaque, and it needs to be removed by a dental professional. So you can't remove it at home by yourself with a toothbrush. PEG-fed patients are much more prone to getting calculus build up due to the pooling of saliva, variation in saliva composition, and the flow rate, and the absence of mechanical friction, which is associated with chewing and oral function. If plaque is not removed, you get gum disease. This is when gums become very red, swollen, they tend to bleed. The early form of gum disease is gingivitis, and this is reversible. However, if it's allowed to progress, you get periodontitis, and this is associated with loss of the gum and the bone that's around the teeth. Essentially, teeth can start to get mobile, get painful, and this may end up with the patient losing their teeth. And then we have one way of assessing the health of your gums is by doing a pocket assessment. As you can see in the picture in the bottom right, it's essentially a probe which is placed between your tooth and the gum, and the depth is measured. Healthy gum is considered to be a depth of around, less than 3.5 millimeters. Finally, we have the term the third-party oral care. This is when an individual requires another person to undertake oral care for them. So when I'm talking about respiratory health in this talk, the main condition we're thinking of is pneumonia. So this is when an acute inflammatory condition that can arise if bacteria enters the distal airways and the lung alveoli. In the majority of cases, antibiotics, be it oral or intravenous, are successful in treating the condition. However, in some cases, it can lead to hospitalization and sometimes death. The recent Asthma and Lung UK charity analysis has revealed that each year, more than 25,000 people die from pneumonia in the UK, while the estimated cost of treating community-acquired pneumonia in hospitals in England alone is approximately £731 million every year. Therefore, anything that we can do to potentially reduce the risk of pneumonia could have a significant impact in terms of lives saved and money saved as well. The 2 main classifications of pneumonia are CAP, which is community-acquired pneumonia. This is when individuals who have not been recently hospitalised present with a lung infection. This is the most typical presentation of pneumonia. We then have hospital-associated pneumonia, or HAP. This is when symptoms manifest 48 hours after admission to hospital. For the patients at the RHN, we use another term, aspiration pneumonia. Now, this is a concept that pneumonia arises from the aspiration of oropharyngeal secretions or upper gastrointestinal contents into the lungs. Pulmonary aspiration is often a consequence of a swallowing impairment, which is very commonly seen in many patients with a neurodisability. Aspiration pneumonia can occur in both community and hospital settings. In the RHN itself, it's considered to be a community setting. The development of pneumonia is multifactorial, and there are a number of medical and social risk factors that could lead to an increased risk of pneumonia. And this slide just shows a few of them. Yet even when all these factors are taken into account, researchers have found that oral health exerts its own effect and can feature as a significant risk factor in the onset of pneumonia. When we look at the studies that link oral health and pneumonia, they tend to fall into two main categories: your cohort studies and your clinical trials. The cohort studies that have been based out in the community select a group of participants who are then followed over a period of time. They assess their oral health at regular intervals and record the number of chest infections the participants experience. Within these studies, there have been a number of oral health measures that have been identified as important risk factors. These include the presence of plaque, decayed teeth, third-party oral care, the frequency of toothbrushing, the presence of carcinogenic and periodontal pathogens, which is basically bacteria that causes decay and gum disease, and periodontal pockets more than 4 millimeters. Whilst in the clinical trials, participants were split into a no intervention group and an oral care group. The interventions have included various things such as the use of chlorhexidine gels and mouthwashes, regular professional cleaning by a dentist or hygienist, and the employment of an oral hygiene aide who is basically responsible for encouraging oral care and helping those who can't provide it themselves. They have all found that improving oral health can in fact kind of reduce the risk, the occurrence, and the progression of pneumonia. When we look at things at a microbial level, there kind of are two theories that link oral health to pneumonia. So one, oral bacteria is released from dental plaque into saliva, which is then aspirated into the lungs, causing the pneumonia. The second is that dental plaque is colonized by respiratory pathogens, and then this gets aspirated, subsequently causing the pneumonia. It's a second concept that has gained momentum in recent research. So Scanapico suggests three mechanisms by which oral bacteria promotes the colonization of respiratory pathogens in the oral cavity. So firstly, periodontal disease-associated enzymes modify mucosal surfaces to promote adhesion of respiratory pathogens. Two, there's an increase in oral bacteria, leads to an increase of salivary hydrolytic enzymes that break down mucins, which aid in normally kind of clearing the respiratory pathogens. And thirdly, cytokines are released by oral bacteria adhesion, leading to changes in respiratory epithelium, again promoting colonization. However, at present, a lot of these are hypotheses rather than firm facts. It's not entirely known how aspiration of bacteria leads to infection in some patients and not others. It's likely a combination of factors, including the frequency and volume of aspirated material, the efficacy of airway and lung clearance mechanisms, comorbidities, the patient's immune system, and the virulence of the bacteria involved. Looking specifically at patients with a neurodisability, there are certain risk factors that predispose them to developing aspiration pneumonia. So firstly, it's the impaired swallowing reflex, which tends to be caused by damage to the central or peripheral nervous system, which means that they are much more likely to aspirate. The second is that the majority are medically compromised and are taking a number of medications, including those that reduce the amount of saliva in the mouth, therefore, in effect, increasing the concentration of bacteria per drop of saliva aspirated. And finally, self-care amongst individuals with a neurodisability can be compromised, whether this be because of impaired motivation, cognitive decline, or kind of reduced manual dexterity or voluntary motor function. It often means there's a reliance on a third party brushing their teeth, and this presents, its own challenges and can lead to higher plaque and calculus levels amongst this group of patients. At the RHN, we have done two studies. The first one asks, does the poor oral health increase the risk of chest infections in adults living with a neurodisability who are PEG-fed? We included, so all those who had at least one tooth were invited to participate in the study. Those excluded included patients who were edentulous, which is basically they have no teeth. Those who are undergoing rehabilitative care, as they may not have been staying for the entire study period, or those who had had a scale in the 1 month prior to the assessment. For the research, so every participant had a dental exam where we measured the number of teeth, the plaque levels, calculus level, if there was any caries, and we assessed gum health and gum pocketing. We then assessed the medical records and recorded any factors that could also increase the patient's risk of getting a chest infection. For example, do they have any existing COPD, diabetes, a history of smoking? Finally, we recorded the number of chest infections the patient had 4 months before the dental exam and 4 months after. I'm just going to go through some of the challenges that we face when doing this research. So patients with a neurodisability often exhibit exaggerated or abnormal oral reflexes, such as grinding and clenching, abnormal limb and trunk movement, and facial hypersensitivity, all of which can make dental examinations extremely difficult. There may also be a lack of cognition, which means that the patients don't understand, why you were there and what you were doing. We also had to think about the timing of our appointments, as we had to consider when the patients were getting up, dressed, bathed, and if they had any other engagements, be it with their families or other teams at work at the RHN. So our solution was to use very quick, minimally invasive measures that would hopefully achieve maximum patient cooperation and also reduce how much distress we were causing to patients. This also included kind of doing only part mouth assessments where only one tooth per sextant was assessed. We also timed the examinations to suit the individual as well. So in terms of our demographics and what kind of the results were, so we had 61 participants in total. The age range from 21 to 79 years. The female to male ratio was 43 to 57, and 72% of the patients were PEG-fed only. Medically, 28% suffered a condition that could increase their risk of getting a chest infection. The main findings of our study were, firstly, over the 8-month period, 51% of the patients included in the study suffered a chest infection, and 7% of those needed to be hospitalized. These are really high numbers. In other cohorts during a 9-year study period, 22% of individuals in a nursing home got a chest infection. And I think, what this shows us is that patients who are in long-term care at the RHN and are being PEG or PEG and oral fed are at a high risk of suffering from a chest infection. Secondly, when we looked at all the factors we measured, be they dental, medical, or social, and tested to see how strongly they were associated with getting a chest infection, our analysis revealed that only the number of medications was a significant predictor of pneumonia status, suggesting a link between the patient's overall medical health and their risk of getting pneumonia. And although no individual medical condition recorded was found to be significant in its own right, I think we have to consider the cumulative effect of a patient's existing medical condition on their risk of getting pneumonia. But looking at oral health factors, what was really interesting was that patients who exhibited periodontal pockets with a depth greater than 3.5 millimeters had 13 times the odds of getting pneumonia when compared to people with periodontal pockets of less than 3.5 millimeters depth. I think in simple terms, basically patients who had worse gum health were more likely to get a chest infection. However, this was not significant when other variables were taken into account. In conclusion, from this study, it was clear that adults with a neurodisability who reside at the RHN are at higher risk of suffering a chest infection. And the two big kind of risk factors were the number of medications and periodontal pockets. Now, with the number of medications and the patient's overall medical status, there's not much we can do to improve that, continually for the long term. However, when it comes to variables, gum health is something that is variable and is something that could be easily modified and improved upon as a means to mitigate the risk of chest infection. And this made us think, what changes can we make to improve patients' gum health, and could we reduce the risk of our patients experiencing a chest infection? This leads us to our second study and our second question. Would daily toothbrushing, once with 0.2% chlorhexidine gel and once with fluoride toothpaste, improve oral hygiene and reduce the occurrence and frequency of pneumonia in adults who are PEG or PEG and oral fed? So firstly, what is chlorhexidine? So chlorhexidine is a broad spectrum antimicrobial that can target gram-positive, gram-negative bacteria, viruses, yeast, and fungi. It can adhere to the hard and soft tissues within the mouth and has been found to suppress salivary bacterial counts for several hours. It's available in several different formulations from 0.06% through to 1%. It can be in the form of a gel, a mouthwash, or a spray. Within dentistry, one of the key uses is to help control plaque levels and gum disease in patients, but is only ever considered as an adjunct to and not a replacement to mechanical plaque removal, so basically toothbrushing. The question we then asked ourselves was, if we introduce chlorhexidine into the regime for our patients, could this reduce oral bacterial load? Could it improve gum health? And therefore, could it kind of reduce the incidence of pneumonia? There are studies that have shown positive results with chlorhexidine, but there are also studies that have shown concerns, such as an increased mortality rate in non-cardiothoracic ICU patients. Of note, though, there are very few studies that look at this very specific patient group. At the time we did our study, there was only one other. So before the study, all our long-term care patients at the hospital received standard oral care, which was toothbrushing twice a day with a manual toothbrush using a non-foaming fluoridated toothpaste. All the patients required third-party assistance for toothbrushing, therefore care was provided by either the nurses or healthcare assistants. Before the study started, all the wards managers, nurses and healthcare assistants received face-to-face training and a demonstration of oral care. Staff were asked to kind of use these oral care techniques, and basically for the intervention, we asked them to substitute the morning toothpaste with chlorhexidine. And the chlorhexidine we used was the one that you can see on your screen, which is Perikin, which is a 0.2% chlorhexidine gel. This would allow patients to kind of benefit from the continued use of fluoride toothpaste as well. The new oral care intervention was performed every day for 12 months, so from February 2017 to January 2018. To further kind of embed the intervention into the daily kind of care routine, information posters were placed in the participants' rooms to act as a visual reminder for staff, and the chlorhexidine gel supplied was labelled with the word morning. So all our long-term care patients at the hospital who were receiving nutrition via PEG or a combination of PEG and oral were invited to participate in the study, providing they were over the age of 18 and they had teeth. The exclusion criteria included patients who had no teeth, who had a known allergy to chlorhexidine, or in patients who had used chlorhexidine orally in the year prior to the study. In terms of our outcomes, so all patients were examined prior to the implementation of the intervention. So that was our baseline, and then every 6 weeks. So that gave us 9 data points. We assessed changes in oral health. So we measured the amount of dental plaque present and the presence of periodontal pockets. We also collected samples of dental plaque with swabs to assess whether bacterial pathogens associated with pneumonia were present within plaque. And then we finally collected data on the episodes and frequency of pneumonia experienced by patients prior to the intervention and then during the study period. And we also looked at the number of chest radiographs that were taken, the number of courses of antibiotics, and the need for hospitalization. So on to the results. So 49 participants in total. The age ranged from 25 to 82 years. The ratio between female to male was 28 to 21. The majority were PEG-fed only, so about 84%. And medically, 35% suffered a condition that could increase their risk of getting a chest infection. So this included, again, COPD, diabetes, or congestive heart failure. So the main findings of our study were, firstly, plaque levels and the proportion of patients with periodontal pocketing over 3.5 millimeters significantly reduced by week 12, and these improvements were sustained to the end of the study period. At any one point, at least 65% of our patients were found to have bacteria that were known to cause bacterial pneumonia in the dental plaque samples. These numbers went up and down over the year, but by the end of the year, there was no significant difference to the levels that had been recorded at baseline. And finally, onto the pneumonia data, we found that the total number of pneumonia episodes, the use of antibiotics, radiographs taken, and hospitalization admissions for chest infections reduced during the intervention period, so during the study period. Hospitalizations dropped by 31%. However, these reductions were not significant. Also of note, there were no adverse events in our study. As with all studies, we need to also look at the strengths and weaknesses that may impact the strength and reliability of our results. So the study was planned. I think one of our key strengths was that the study was planned with the understanding that, for patients within the RHN, and to be honest, patients within many hospitals and residential care sites, oral care can be undertaken by several different members of staff of varying grades and skills. So we wanted an intervention that was realistic, practical, and quite importantly, sustainable for the long term as well. And in addition, kind of unlike a number of studies, we also assessed what could be viewed as the middleman, so the oral health outcomes, and not just the pneumonia data. But in terms of our weaknesses, it's really difficult to ascertain whether the improvements we saw in oral hygiene and gum health was due to the chlorhexidine, or was it due to the improved technique of the ward staff, or perhaps even the ward staff knew that we were coming, on the wards regularly to have a look at the patient's oral health, were they just, kind of on top of their game a little bit more, or it could have been kind of all these factors combined. Although it was justified using kind of partial measures to assess oral health, it carries the risk of either overestimating or underestimating levels of disease. So I think our results should be viewed as an observed trend rather than exacting results. And with regards to the swab samples, they were taken at different times of the day. So we don't know, if they were done before or after oral care. And finally, this is a very small study. So our sample size is small and we're not a randomized control trial either. So at the end of the study, we're not in a position to say that we should be using kind of chlorhexidine gel daily within PUTNY. Although there were no adverse oral side effects reported in our study, regular chlorhexidine use has been linked to causing discoloration of teeth, tongue, fillings, and mucous membrane irritation and taste disturbances. In addition, the widespread use of chlorhexidine has led to increasing concerns that bacteria are able to adapt and develop resistance to chlorhexidine. And we have the concept of antiseptic stewardship, which emphasizes the need to restrict chlorhexidine use to application with clear patient benefit. 0.2% chlorhexidine mouth rinse itself is only licensed for 30 days use, and use beyond this time period must be justified with professional supervision and in conjunction with mechanical means of plaque removal. So basically good toothbrushing. What we really need is a large multi-center randomized controlled trial to fully assess the benefit of regular chlorhexidine use in this patient group as a means to reduce the risk of pneumonia, which if you're interested, please contact me because we'll be happy to kind of do work with other people. But I do feel overall that our studies, add to the mounting evidence that oral health is linked to respiratory health. And I think, our key message is that maintaining an individual's oral health can have a big part to play in maintaining quality of life and well-being. And actually, we need to focus on establishing oral care programs that focus on the basics. So things such as really good toothbrushing done twice a day, and hopefully, as well as improving oral health, we can also reduce the risk of aspiration pneumonia for our patients. I'm now going to pass you on to Louise, who will take you to the next part. Oh, yeah, of course.
I know.
Just bear with a second, sorry.
Thank you, Mia. Thank you. Good afternoon, everyone. My name's Louise, and I'm just going to talk to you briefly, just a little bit about oral care. So why is providing good oral care important? Well, a clean and comfortable mouth is important for quality of life and dignity. It's the first thing that patients' families mention to us, especially if there's halitosis. It can be quite upsetting for the family. So that's one of the reasons why it's really important that we do provide oral care. Regular mouth care is important to remove plaque, which contains bacteria. As Ria mentioned before, poor oral health is linked to a number of general health conditions, such as chest infections. And poor oral care can lead to tooth decay. So we've already got the plaque forming on the teeth. Once we have sugar, that's when we get tooth decay. The bacteria can irritate the gums, cause inflammation and cause gum disease, which is when you see bleeding on brushing. It can cause chest infections and oral thrush. So patients who are not orally fed still require good oral care. Although they're not prone to get tooth decay, they are prone to gum disease. So it's really important that we brush the gums to keep the mouth nice and clean. So Ria already spoke about plaque and calculus, but I'll just go over what they are. So plaque is soft, creamy, sticky, and full of bacteria. It can be removed effectively at home with a toothbrush, and it can cause tooth decay and gum disease, and it's linked to chest infections. Calculus is just hardened plaque. It calcifies in the saliva. It cannot be removed by a toothbrush. You will need to visit a dentist to get it removed. As Ria said before, it's common in non-oral fed patients. We can clean it off, and then in a few months' time, when we're seeing them for a review, it's there again. And that's quite upsetting to patient families. So we do try and remove here as much as we can. But we do always let families know that there's a possibility that it will come back very soon. And we need to keep the calculus clean. We don't want the plaque and bacteria to form on the calculus. So we need to make sure it's nice and clean so that, again, it doesn't cause any gum disease. So why can providing oral care be challenging for patients with a neuro-disability? Well, some patients with a neuro-disability, it's their posture. You may see patients who have their head, down on their chest. So we always recommend, if you're working in pairs, someone can help support the head while the other person carries out the oral healthcare. They may have care-resistant behaviour, so they may push you away or tell you no. We recommend that trying different times of the day or working in pairs again, if someone supports the patient, while the other person cleans the teeth. You may want to check different times of the day, maybe different music, their favourite television programmes on in the background. That sometimes help. They may have a bite reflex. So every time you go to brush, they may bite down onto the toothbrush. We've got here that we use at the hospital are finger stools. I should talk a little bit about them later on, but just like those. Dysphagia, patients with neuro-disability may have dysphagia. Always speak to your speech and language team or refer on to a speech and language team, and they can give you support. But still, patients with dysphagia still need oral care. So we recommend, again, working in pairs, someone with the suction while someone provides oral care. And they may have limited mouth opening, so it might just be really tricky for you to actually get a brush inside a patient's mouth. But if you can still keep clean the surfaces that you can see, that's better than nothing. So how can you provide good oral care? Always ensure that you've got appropriate mouth care products, that you've got your toothbrush, your toothpaste. Assess the level of support that the patient may need. Sometimes it's obvious to see that a patient does require support, but sometimes a patient may look able-bodied, but it may be that they just need you to bring over a bowl their toothpaste, their toothbrush, putting the toothpaste on the toothbrush. They then may be able to do it themselves. They may just need you to gently hold a hand over there to support them while they provide their own oral care. It's really important that mouth care is put into their care plan, so that it's carried out daily, and that they can attend regular dental reviews. Reach out to your local community dental service for dental reviews for some of your patients if it's tricky for them to attend a dental practice. Remove and clean dentures. So plaque still forms on dentures. We really need to make sure that we're taking those out, we're cleaning them, we're removing any food debris that's on there, because they can cause soreness and oral thrush. And to provide mouth care assessment and recording forms. Always report or record when you've done oral cleaning. We here use mouthcare assessment forms. I've got them on a slide in a moment to show you as well, just in case you want to implement them at your place of work. So here we are, here's our mouthcare assessment forms. Basically what we do is weekly here, the healthcare assistants or nurses will look at patients' mouths using a light source. They'll just assess the lips, make sure they're nice and healthy. Are they not cracked? And then if they are, then it will tell you to refer on to the dental service or medical team. So those are just pictures there. I'm happy to send on a mouthcare assessment form to you if this is something that you'd like to implement in your place of work. So products to help provide oral care. We always advise working in pairs because it can be tricky. Whilst one person is providing oral care, the other person can support the patient, talk to the patient, maybe that you need to hold the head or use a yanker suction. A small head toothbrush. So I don't know if you can see that. So we always recommend a size 30 toothbrush, or even still a children's toothbrush, especially if it's limited mouth opening. Those are the best. So for toothpaste, you can use sodium lauryl sulfate. So that's a toothpaste that doesn't foam, which is a lot easier, especially if you are concerned about dysphagia. It comes in just a mild flavour, or it has no flavour at all. So if you've got a patient who doesn't eat, introducing flavours may be a bit distressing for them. So that's always good to have for them. Pink foam swabs are banned here at the hospital just because they pose as a choking risk. There was an incident in Wales where the pink part came off and a patient actually choked on that. So we found other alternatives. So the 360 brush, I don't know if you can see it there on the screen, but it's just a round brush. It can hold a teaspoon of water. It's nice and soft, so it's good for cleaning the tongue, the palate and the soft tissues. Or we have these little mouthies brushes. Pictures are on the screen as well, and I'm happy to forward you any of the details of where to get those if you'd like to get them. So as well, a 3-headed toothbrush. Now this is really great if you've got a patient who isn't very cooperative, will only open their mouth for a short period of time or tires very easily. I'm going to try and show you, I'm not sure if you can see, but this is my little tooth model here. So this 3-headed toothbrush can just get the back of the teeth, just like that, and it's a lot quicker and easier and less distressing for a patient who cannot keep their mouth open for long. Ria talked a little bit about secretions. So what we use here is a dry mouth gel, and it's good to use with the mouthies. If you've got secretions on the tongue or the palate, it's really important though to rub those in. You can either use your mouthies or your a normal toothbrush. Really important though, like you would cream on eczema, to rub that in. Otherwise, you can find that secretions just build up onto it. So we really need to rub that in. We also always recommend a light source. The mouth is quite dark, so if you've got a pen torch, you can see areas at the back of the mouth that you might miss when just licking. And I talked a little bit about the finger guard a moment ago. Now, this is really good if you've got a patient who has bite reflex or tires easily. I'm going to try and show you as best I can here. So if you've got a patient that bites down, you put your finger guard in. Once they bite down, I need extra hands here. You can still get your toothbrush and you can go in and you can still provide oral care. Again, always assess the level of support, especially for stroke patients as well. You may think that they may be able to brush their own teeth, but sometimes after they've eaten, sometimes the food can stick inside the cheek. So it's really important that we clear that away just for comfort, and because as well, we're worrying about tooth decay. Speak to the SLT if you're concerned again about dysphagia. And here at the hospital, we do offer a one-day training day on oral care, so we'll go through this in a lot more depth if you'd like to join. Thank you very much.
Brilliant. Thank you, Ria and Louise. Thank you so much for presenting. So we've got some time for questions now. So if anyone has got a question, please do put it in the Q&A tab. We've got a few, so I'll start. So firstly, we've got a question from Amy, who says chlorhexidine is no longer a recommendation in prevention of VAP. Yeah. Is there a reason for this? And should we still be using this with ventilated patients?
Oh, yeah, I am. I think the reason was because I think it's the lack of evidence that supports its use. And I think, like I said, there were concerns about it, kind of the mortality rates and stuff like that. So I think you need to follow the guidance. I think the guidance is saying don't use it. So I think don't use it. I think we just need more evidence before, if that answers your question. I suppose it's kind of no, but I think it's kind of, we need more evidence before we can have it regularly. Really, that's why we don't use it in the hospital regularly here.
Okay, thank you. We've got another question. Are the majority of these patients having regular chest physio?
That I assume, I don't know, you'd have to speak to the physio team for that one.
We can always find out.
Yeah.
And get back.
Oh yeah, sorry.
We can always find that out and get back to you with that question.
Okay. Brilliant, thank you. So Eleanor asks, did some of the participants receive inconsistent input? Sometimes it can be difficult to give thorough oral care to some of our neuro patients for some of the reasons you've mentioned.
Yeah, I think it's a case of the staff were doing the best job they could for the patients, which is what they do every day. So, it's never going to be as thorough as, say, for me or for Louise, but it's the best that they can do, and that's all we can ask for them.
And we've got another question. Would you be able to share the mouth care assessment forms?
Of course.
The hospital I work at doesn't have a dental.
Oh, no, that's absolutely fine. If you could just leave your email address, what would be the best way? And I'll send you that over.
So we've got an email address. If we don't get your question today, our email is institute@rhn.org.uk. So I'll type that down for you as well. But do just drop us an email and we can send that over to you.
And we've also got the dental email address up on the screen. Is it still up on the screen now, Anna? Yeah. If you can see that, email us and we're more than happy to send those over. And we've got the picture that goes with it, so you can see what with the form, how it corresponds.
Perfect. So that email address, if you can't see it, it's dental@rhn.org.uk. Amy asks, what about Sage Q4 cleansing and a suctioning system for ventilated and non-able-bodied patients?
So that just suctioning device?
No, sorry,
no, it's okay.
You
might have to describe what it is.
Maybe Amy can tackle
Yeah.
that. The question was, what about Sage Q4 cleansing and suctioning system?
Yeah, we
We
don't
don't
use
know
those
that,
here, so I
sorry.
don't have any
Yeah.
idea about those. Sorry.
Yeah.
Okay.
Sorry, so the participants that we have in our study are not ventilated, just to kind of make that clear as well.
Okay. Another question. It would be, oh, well, it's a statement. It would be interesting to have information about the 360 brush.
Yeah, I can give
mouth
information about those. So these 360-degree brush, I believe they're from Oraleave. But of course I can give you more information on those. If you work with children, they come in smaller size as well, or if you've got a patient who has limited mouth opening, yeah, they might be better still. So yes, we can send out all the information if you require them. If you email or let us know, we can send out those details for you. I can send out you the details of all of the products that we use.
Thank you. Caroline had a question around those patients who suffer from high levels of calculus.
Yeah, that's right.
Calculus buildup
Yeah.
and can't cope with its removal in clinic. What are your views on the appropriateness of regular sedation, GA, to remove?
We don't.
So I think it has to be, it's like with every clinical decision, it's a kind of a risk versus the benefits of doing it. You know, obviously with sedation, you know, it is less riskier, you know, than a general anesthetic. So I definitely wouldn't be doing kind of regular general anesthetics to scale somebody's teeth. You know, sedation, potentially, but obviously, you know, I think you need to make sure that when you're treating these patients that you are managing, and also kind of, I think you're treating them in such a way to reduce the risk of any aspiration whilst you're doing the scaling. So making sure that you're treating them upright, you know, perhaps using hand scaling, or if you're going to use the ultrasonic scaling, so the scaling with water, that you're, you know, you're able to get really good suction in there with a high speed and a slow suction.
And also how they will be with the sedation, the
Yeah,
sats and
exactly. So I think
like that.
you know, I think it's always with everything. So, you know, if you know it's a patient who sedates very well, then yes, it's something that you could consider doing more regular scaling on. But I think if it's a patient where you have concerns about sedating them, perhaps their sats are low or they're very medically compromised, you know, then on balance, actually, you know, should you really be, you know, removing that calculus, especially when, you know, the calculus may be there, but actually the gums are looking quite healthy and pink. You know, it's, yeah, as with anything, I think, yeah, I think it's with anything, it's obviously keep the calculus clean as well. Yeah. You know, I think as with any individual, you know, I think with any patient, it's always very dependent on that individual. And I think you need to kind of cater your planning accordingly.
And you can clean it off, but the calculus always comes back.
Yeah, especially in our peg bed patients, we can
yeah.
do the scaling, but it comes back really quickly.
So that's something that we need to consider as well.
And I think it's making sure that when you're speaking to, you know, family members, if you're having to go through a best interest, that you also highlight that to them as well, that, you know, you could do the scaling under sedation, but actually it may very quickly come back again, you know. So, you know, I think everybody knows what the expectation is of that. I hope that answers the question.
Thank you. So we've got a question now from Claire. Do you know whether there's any way mouth ease sticks can be provided by GPs or DMs on prescription?
I don't know about that, but I know that you can get them off NHS supplies or on the internet. I don't think
it's prescriptive.
It's not a prescription. It's not a prescription. You can just get them off.
It's like a toothbrush, really, isn't it?
Yeah.
Okay. And a question, what would you recommend doing if you can't actually open, or a patient refuses to open their mouth?
So that can be really tricky. And in that instance, I would always say contact your dental practice or community dental service. The patient benefits seeing a dentist, but you know, there is no magic wand. Sometimes here, when we've got patients who can't open, we do sedate so that we can have a look inside patients' mouths. And if there's no dental reason, then we just say, just brush the areas that you can see. It's not ideal, but it's the best that you can do for that patient.
Okay. We've got a question from someone, this is a more broad one. What advice would you give to hospitals who don't currently have any mouth care nurses or inpatient dental services?
Well, I don't want to you know, sell us, but we do actually do an oral care training day, and in that we do talk about implementing it into your setting, how to get people to listen to you so that you can provide this in, you know, getting funding or just speaking with the heads of departments to listen, so that this is something that everybody's on board with and you can implement it. And we've got all the tools and things on our oral care training day, so if you can come along, it would be really good.
Yeah, I think you almost, you know, I think nurses, you know, a nurse can take responsibility, whereas you're almost having like an oral care champion, you know, for the ward who takes responsibility kind of for, I suppose, enrolling this and kind of, you know, keeping an eye on it and things like that. So I don't think you necessarily need a regular dental input, because I think it might be really difficult to get one. But I think, you know, if you give somebody the training and then they can cascade it to others and maintain that, I think that's really important.
Yeah, our healthcare assistants here carry out all of our mouth care and fill out our mouth care assessment forms, so they're all trained. I guess it's just training somebody though who can then take the lead and carry that out in your place of work. I hope that answers your question.
Keep saying that.
Hopefully so. Amy's come back to us just to clarify. So for her questions, she said, sorry, they're a suction tool with a cleansing pouch with mouthwash in. She's not sure what's in the ingredients, and she'd like to know your opinion.
I would just say speak to a dentist to see if it's safe, or your SLT team to see. Sorry, is that Amy and SLT?
Yeah. No, I think it's somebody who obviously works in a ventilated unit. I think.
Yeah, I would say speak to a dental team or SLTs about that. It's not something that I'm familiar with, so I couldn't answer that question. I'm sorry.
Yeah, I'm sorry, I've not seen. I think you'd almost have to see one in action and see what it's used like on a patient.
Can we note that though, Anna?
Yeah, we'll find out about it.
Okay, brilliant. Thank you.
Thank you.
We've had one question where it say, presumably using the finger guard for patients who may not be able to consent to provided oral care in their best interest. What are your thoughts on consent and when patients demonstrate resistance to opening or participating and using the guards in this case?
The thing is, though, I don't think, it is possible. I don't think we ever, if a patient's looking kind of distressed.
We'd never force.
We never force one in. And I think, you know, with everything that we do, it's a case of making sure that the patient is not distressed or going under, you know, any undue harm by what we're doing. So I think it's, you know, I think, you know, we use it in situations where we can, where where patients will tolerate it. But, you know, if a patient is getting distressed by it or is causing them pain, then obviously we stop using it.
Okay. And I suppose it's along a similar theme. What advice can you give for supporting patients who decline to have their dentures removed for cleaning?
I mean, it depends. Do they on capacity on a number of things, doesn't it?
You know, if a patient has capacity and they're saying they don't want it removed and they understand the risks of it not being removed, then actually you have to respect, you know, a patient's decision to make an unwise, what we would consider perhaps an unwise choice. For patients who lack capacity, perhaps there's a discussion that you then need to have with the next of kin to let them know, you know, this is what you feel and this is what you feel that would benefit the patient would be taking out the denture. So I think you first need to do a capacity assessment, and then I think your actions will get taken from there.
Okay. The next question, what would be your recommendation for a PDOC patient, so someone who's in a prolonged disorder of consciousness with obviously decayed teeth whilst waiting for a dental appointment? Staff have expressed valid concerns about causing pain during mouth care.
Okay.
So they're waiting for a dental appointment.
So they've not had a dental appointment yet. Yeah. I almost think if you can, it sounds silly, but I don't know whether going to see an emergency dentist, depending on which site you go see them, you might then be directed quicker into the services who could actually treat the patient. I think, because it sounds like if a patient may not accept treatment in the local anaesthetic alone, and you're looking at either the sedation or general anaesthetic, you want to get them to a service that provides that as quick as possible. And I do wonder whether, rather than just waiting for a routine dental checkup, whether you can push it and say it's an emergency and see an emergency dental service, whether things will just go a lot quicker. Kind of working, as well as working here, I work in a bigger hospital and we often triage referrals. And if it's identified that the patient's in lots of pain or having swellings, you know, we would scooch that referral up and see the patient quicker. So maybe it's kind of looking into getting to an emergency dental service. I think, I don't know whether you have any better ideas on that.
It's tricky for everyone at the moment.
It's the thing,
actually
you know,
accessing
it's so hard at the moment, and our waiting lists are just so long, I think, for care, unfortunately.
Okay, so Alania's asked, how would you manage loose teeth in an acute setting?
Okay, so Lucy, it kind of depends how loose the tooth is, if that makes sense. So as a dentist, we kind of assess, you assess on 3 levels, basically. So one that's not so loose is something that could be regularly kept an eye on. Something where you think, oh, this is really loose, it could be an aspiration risk and it needs to be taken out. Again, it depends what kind of acute setting you're in. So a lot of hospitals, even if you don't have a dental hospital attached, should have a MaxFax team. And the MaxFax team, generally, if you contact them, should come and have a look at the patient. And if they feel that the tooth is an aspiration risk, then they should be able to take that tooth out for you, hopefully. And I suppose that's the best way. Some acute trusts obviously would be linked to a dental hospital. So you'd have like special care dentists, such as myself and kind of Louise, who'd come and see the patient. So yeah, I think it's finding out whether in your acute setting, is there any access to any dental kind of input is what you need, really, because it sounds like if you've got a very loose tooth, it sounds like it needs to come out. So you need a dentist.
Okay, next question. What is the recommended frequency of mouth care for someone with a PEG, and does this increase when they have dysphagia?
You still need to carry out oral care
Yeah.
twice daily, if that's in their care plan. I know sometimes it's not always easy to incorporate that, but yeah, mouth care still needs to be provided twice a day for anybody, really, whether they're PEG fed or
No.
Yeah.
Okay. We've got a question here. How much did enteral feeding impact on patients getting aspiration pneumonia?
So we didn't actually look at patients who weren't PEG fed. So only the patients who were PEG fed or PEG and oral fed were included in the study. And we didn't actually separate the results further by having just PEG fed patients and PEG and oral patients, if that makes sense. So actually, yeah, I think our results should just consider for PEG and not for non-PEG patients.
Okay, so following on from that, Lizzie says, I was wondering for patients who were PEG fed only, whether there was a recommendation for more frequent oral care. Where I work, she says, we offer oral care 4 times a day for patients who are nil by hand.
That is amazing.
Standard.
No, but that's brilliant. If you've got the facilities and the staffing to do that, then
I think, you know, a lot of it also depends on just what is, as I mentioned before, sustainable, you know, in your care setting, and what's achievable in terms of, you know, what the nurses can achieve. You can do it 4 times a day. That is just incredible.
Yeah, you'll find that some places they can only have time to do it once a day, so that's amazing. Yeah.
Okay.
No, we're in awe.
Lizzie she then had a second comment. She said also sometimes mouth care may be planned, however not always consistently completed, so due to some of the reasons that you touched on, Louise. Was the manual oral care actually delivered taken into account when analysing results?
So so we weren't able to, you know, we didn't include how consistent and how well the manual kind of oral care was being done each time. And, you know, we didn't watch any of the nursing team deliver the oral care for the patients during, you know, the year or the 8-month period. You know, it was carried out the way, I suppose, it would normally be carried out if we weren't doing the study, essentially.
Okay. We've had a few questions about the slides. So we won't send the slides around to you all, but if you would be really interested in having a copy, do get in touch with us and we can send you the majority. We might just take a few things out. So do get in touch with us if you find that really useful. This lecture also, just to add, is being recorded. So we'll make it available in the next few days. So if any of your colleagues or anyone was interested and missed it, it'll be available on our YouTube page in a few days' time. So do catch us again there. We do have a few more questions, so hopefully
let's
carry on. Brilliant.
So like you're giving us a grilling.
It's like being into your studies were done in long-term care. What's happening in rehabilitation?
So the oral care and rehab is exactly the same, but we didn't include the rehab patients for our study because our study was going for either an 8-month period or a 12-month period, and a lot of the rehab patients may be discharged at various points.
So, normally it's a 3-month placement.
Yeah.
So that's why, unfortunately, we can involve rehab patients here.
Yeah, but that's something that could always be looked at for the future, though.
Okay. Someone, it's just referring back to another question, just talking about the Orally, they're 360 brushes and they come in pediatric size, which is useful if a patient has poor mouth opening. So that's good to know too. Someone's asked, could you give a bit more insight into using the finger guard?
Yeah, so basically, I'll do my best with the screen. So basically, if you've just got someone biting down, it's really important when you do use the finger guard that you've got your forefinger in and then you're holding it, because what we don't want is essentially a patient to bite down and then we lose the whole thing. So it's just really, if a patient can open their mouth, would never use it on a patient who's very tight and can't open at all. But if they've got a slight opening and we can put the finger guard in safely and then they can bite down, that's how we would use it. We would never force it into a patient's mouth, because as well, you know, we need to take it back out as well. So that's basically, if you can fit it in, never force it. And then if you've got two people, if one person holds it while the other person brushes the teeth and provides oral care, that's the best way to use it.
Thank you. Brilliant.
But we do have the day of oral care.
So we've got some training coming up. I need to check the date, but we'll be releasing all of our training events towards the end of November. So do check our website then. We'll be running it next year. So you'll be very welcome. We'll be hosting it here at the RHN. So come and join us. We've got a question. The advice sheets. Do you have any advice sheets about how to carry out oral care for people who are peg fed? If so, could you
we do have some form. I don't think we have one on peg-fed patients.
Not specifically on
but
peg-fed
it would
patients,
just
but it's
be
kind of
the same. It's the same healthcare that you would do for normal patients.
We do mention
peg-fed.
about, I suppose, care for the patients with dysphagia, so things like the suction.
Yeah, so that would just be just if you're worried about dysphagia, contact your SLT, but we still do provide the same care for everybody. Everybody gets.
Yeah, I think we probably do have leaflets maybe for patients, just saying
we have oral care for patients with
neuro-disability,
and it might mention that. So we're happy if you want any fact sheets, if you email Anna or the dental@rhn.org.uk, we can certainly make sure that you get a copy of those.
Brilliant. I think we've got one more question here and then we could probably draw to a close. Do you have any tips specifically on how to access a patient's oral cavity when they're biting down?
So if they've got a bite reflex, like I said, possibly the finger guard, but you just want to be careful, obviously. And it's not everybody wants to use the finger guard, so it's up to you whether or not you use that. But yeah, I don't really.
I suppose it kind of depends. Sometimes I find that patients who start clenching, if you start brushing the teeth, sometimes they'll open up a little bit as well. I think it's. Sometimes it's just difficult.
Sometimes if you just start brushing the lip and then introduce like a little bit of toothpaste on the lip, you'll find that they may lick their lips and then something clicks. Oh, okay, I'm going to have oral care now. And then sometimes you'll find that a patient will actually open their mouth and that you can carry it out. But at the same time, still, you possibly using a finger guard alongside that may help.
I suppose, it's probably saying the obvious and something that you probably always do anyway. But I think telling the patient what you're, introducing yourself, telling the patient what you're doing, what things you'll be using as well. To prepare them for it,
because it can be quite invasive. Someone brushing your teeth, so always explain what you're doing always helps.
Right. And just quickly, final question: would the finger guard help with fatigue of mouth being open?
Definitely. That's one of the reasons it's for. Because then if the patient tires, then they can just rest there. I don't know if you can see, I'm so sorry. Rest down onto it, and then you can just carry out and then just take it out and then place it onto the other side and continue.
For dental treatment, we actually use little mouth props. You can get varying sizes, again, for patients who get maybe tired of keeping their mouth open but are comfortable having it kind of placed in their mouth. We use that during the dental treatment as well.
Okay, I think we'll stop there. We've got a couple more questions coming in. If we haven't got to your question, do drop us an email. So dental@rhn.org.uk. Also, if you're interested in receiving the slides, again, do get in touch. Thank you so much for joining us today. Thank you to Ria and Louise for presenting.
Thank you.
And we hope you'll be able to join us at one of our future courses or lectures. Thank you, everyone.
Thank you. Bye-bye.